everyone. I'm Shen. I'm a co-director of the Lobular Breast Cancer program at Memorial Sloan Kettering Cancer Center, and this is a talk on early stage lobular breast cancer for our LBCA patient advocates. This is the outline of what I'm going to talk about today. I'll go over the typical treatment algorithm for patients with early stage hormone receptor positive breast cancer in general, not specific to ILC. I'll talk about neoadjuvant, meaning pre-surgery therapy for ILC, touch upon chemotherapy and endocrine therapy. I'll talk about adjuvant, which is post-surgery therapy for hormone receptor positive ILC. I'll talk about oncotype, tamoxifen versus aromatase inhibitor, and CDK4/6 inhibitors, and then I'll touch upon LobCig. This is the typical treatment algorithm for hormone receptor positive early stage, so stage 1, 2, and 3 breast cancer. Going down the chart on the left, for premenopausal women, if they are clinically node negative, we typically have them go for upfront surgery. If there are lymph nodes found to be involved, meaning they're staged pathologic node positive, we recommend chemotherapy. If they are node negative, we use the oncotype score. If the oncotype score is low at less than 16, we don't recommend chemotherapy typically. If the oncotype is intermediate between 16 to 25, we use a variety of factors to help us determine what the benefit might be from chemotherapy, and it's a discussion with the patient. And if the oncotype is 26 and above, we do recommend chemotherapy. If patients are clinically node positive, we typically give neoadjuvant chemotherapy, so chemotherapy prior to surgery. And then after surgery, they get adjuvant endocrine therapy. For postmenopausal women, this is the chart on the right side. If they're clinically node negative, we send patients for upfront surgery. If they are found to have up to 3 positive axillary lymph nodes, so they're staged pathologic N0 or N1, we use the oncotype again. If the oncotype is less than 25, we don't recommend chemotherapy typically. And if the oncotype is 26 and above, we do recommend chemotherapy. If patients who go for upfront surgery are found to have 4 or more involved axillary lymph nodes, meaning they're staged pathologic N2 or N3, we do recommend chemotherapy. Then for patients who are postmenopausal and are clinically node positive, we use the oncotype score to help decide which kind of pre-surgical neoadjuvant treatment we're going to give. If the oncotype is less than 25, we can sometimes use neoadjuvant endocrine therapy. If the oncotype is 26 and above, meaning we were going to recommend chemotherapy after surgery anyway, we could give that chemotherapy upfront prior to surgery. So again, this is kind of a general treatment algorithm. Obviously, this is not meant as medical advice, and each patient should still have their own personalized discussion with their own oncologist, but this is kind of our approach to early stage hormone receptor positive breast cancer. So talking about neoadjuvant chemotherapy in hormone receptor positive ILC as compared to IDC, we know that typically ILCs respond less to chemotherapy than IDCs. And I'll touch upon oncotype a little bit later, but we know that ILCs are associated with generally lower oncotype scores, again, meaning less responsiveness to chemotherapy. So this is from a study that looked at neoadjuvant chemotherapy comparing ILC versus IDC. What I want to highlight is the hormone receptor positive HER2 negative subtype. You can see that the pathologic complete response, meaning we give chemotherapy and a complete response is 0 cancer cells left over at the time of surgery following chemo. That rate is really low in hormone receptor positive breast cancer in general. So in ILC and IDC, in this particular study, it wasn't significantly different. It was just very low at less than 10%. In these other subtypes though, so hormone receptor negative, HER2 positive, and hormone receptor negative, HER2 negative, meaning triple negative, you can see that with IDC, there's certain pathologic complete response rates in the IDC column. And with ILC, it seems to be a little bit lower. I wouldn't put so much stock here in these particular numbers. You can see that This was a pretty small study. Patients with ILC, there were only 3 of them with HER2 positive ILC and only 3 with triple negative ILC. So in general, these other subtypes of ILC are more rare, so less common than in IDC. And so in this particular study, the pathologic complete response rates were very, very low, but again, only looking at a few patients. So I wouldn't necessarily compare that to IDC, and you can see that that's not statistically significant. But overall, it seems that pathologic complete response rates to neoadjuvant chemotherapy across the board for hormone receptor positive, HER2 negative breast cancer are exceedingly low. This was a slightly bigger study, also comparing ILC and IDC neoadjuvant chemotherapy. You can see here that the rate of us needing another surgery, so because of positive margins, another margin re-excision, and eventually a mastectomy, that percentage is higher in ILC. It's 34% in this study compared to 8% in IDC. And then lymph node status after surgery, so even after chemotherapy, you can see that node positive status in ILC was 74% and only 63% in IDC. And overall, the pathologic complete response rate was very, very low. It was only 1% for ILC compared to 9% for IDC. So overall, neoadjuvant chemotherapy, particularly in hormone receptor positive, HER2 negative ILC, does not work very well in eradicating all of the cancer. So we know that the pathologic complete response rates are very, very low. This is a meta-analysis, so an analysis of a lot of different studies. So it's not at the patient level, it's at the study level, comparing chemotherapy and ILC versus IDC. And what we're seeing here is this chart on the right where there's a line down the middle, and you can see that all the horizontal lines are generally to the right side of that line. What that means is that this is showing that IDC tends to respond better to neoadjuvant chemotherapy as compared to ILC. So ILC is on the left of the line, IDC is on the right of the line. And most of these studies are showing better response to chemotherapy with IDC to the right of the vertical line. So what about neoadjuvant endocrine therapy then? This is from also a pretty small study of patients with ILC who got neoadjuvant letrozole, which is a form of endocrine therapy. And what you're seeing here is on the left, clinical tumor volume, meaning by measurement on a breast exam, and on the right, ultrasound tumor volume, so measurement on an ultrasound. And what this is showing is that most tumors have a significant reduction in volume, both clinically and on ultrasound, with neoadjuvant letrozole. So there are some tumors that had 100% reduction. Most fell into the 50 to 99% range of reduction in volume. So most tumors shrunk by over half of the size that they were with neoadjuvant endocrine therapy. So in summary for neoadjuvant therapy, with HER2 positive or triple negative breast cancer, we generally follow the receptor subtype guidelines. So those patients typically do need chemotherapy. For hormone receptor positive disease, though, in general, we know that hormone receptor positive ILCs tend to be less chemosensitive, and there are low rates of pathologic complete response rates in general with this breast cancer subtype, but particularly with hormone receptor positive ILC. So it's a pretty complex multidisciplinary discussion if we think that someone needs neoadjuvant treatment of some kind. So this multidisciplinary discussion involves our surgeons, sometimes our radiation oncologists, about whether upfront surgery versus neoadjuvant treatment is the best thing for that particular patient. And if neoadjuvant therapy is needed, whether chemotherapy versus endocrine therapy is more appropriate. And this is where Oncotype might be helpful in determining how chemosensitive the tumor is. So this is a pretty complex area and requires a lot of thought, I would say, between the multidisciplinary team, the patient, and their oncologist. So in terms of adjuvant therapy for hormone receptor positive ILC, so in the adjuvant setting, we typically use the Oncotype to help guide the chemotherapy decision. Remember that there are a couple of circumstances in which we don't use the Oncotype and we recommend chemotherapy. So that's premenopausal women with node-positive disease and postmenopausal women with 4 or more axillary lymph nodes involved. Generally, for other cases of hormone receptor positive HER2 negative disease, we use the Oncotype score. So that's for premenopausal women with no axillary lymph nodes involved, or postmenopausal women with up to 3 positive axillary lymph nodes. This is a study that was comparing ILC versus IDC in terms of Oncotype scores, and there was a pretty significant difference between having a high or low risk score between ILC and IDC. So in parentheses are the percentages of patients with ILC and IDC. You can see that this one particular category that I'm highlighting, which is clinical high risk, meaning anatomically the tumor is big or there's a lot of axillary lymph nodes, but with a low Oncotype recurrence score, that accounts for about 37.8% of ILCs, but only 24.9% of IDCs. And if you look at the other categories, overall, ILCs tend to be more in the low risk score category of less than or equal to 25 as compared to IDCs. What this bar graph on the right is showing is that chemotherapy is generally used less frequently in ILC than IDC, even when comparing pretty similar characteristics. So along the bottom, the x-axis, this is looking by risk scores. So you can see the first one is ILC, risk score less than or equal to 25 versus IDC, but more and more chemotherapy is given based on an increasing number of positive lymph nodes. That makes sense. But when we look at even the high risk score, where we typically should recommend chemotherapy for high Oncotype scores, even then, looking by lymph node status, node negative in blue, 1 to 3 positive nodes in orange, and greater than 3 positive nodes in yellow, even then there's a significant difference between what oncologists have been giving between ILC and IDC, typically with chemotherapy used less often in ILC. But is that appropriate? So this was a study that looked at comparing ILC and IDC specifically with Oncotype scores. One thing I wanted to show here was that in terms of the tumor characteristics, the proportion of patients with T2 and T3 disease was higher with lobular cancer, meaning tumors tended to be bigger in women with ILC as compared to IDC. And then when we looked at the average Oncotype score comparing IDC versus ILC, the average score was slightly lower with lobular than with ductal. And then when we look at the categorizations, most ILCs in this particular study, 92%, so 20.5% plus 72.9%, ended up in the lower Oncotype risk score of less than 25 range, whereas it was a smaller proportion for IDC, although still most patients with risk scores of 25 or less. And what the graph on the right is showing, this is breaking down IDC in the blue line and the red dotted line with whether or not they got chemotherapy, and ILC with the dotted green line and the dotted brown line with whether or not they got chemotherapy. And in this particular analysis, everyone had a high Oncotype score, meaning they should be recommended to get chemotherapy. So we're comparing patients who have a high Oncotype, who should get chemo, IDC and ILC, did they get chemo or no? And what this graph is showing is that there was a significant difference in overall survival for ILC, particularly when patients did or didn't get chemotherapy. And what that's really saying is that the Oncotype does seem to be accurate in patients with ILC, meaning that it does predict chemotherapy benefit and whether or not we should be giving chemotherapy. So even though it's less common to have a high Oncotype score in ILC, when the Oncotype score is high, patients do benefit from chemotherapy, even in ILC. Now shifting focus to talk about adjuvant endocrine therapy. There is some thought based on preclinical, meaning not in humans, like studies in petri dishes or in mice, that tamoxifen might work particularly not well in ILC due to the mechanism of action and how ILC cells are. When we looked at this in a big clinical trial that compared tamoxifen to aromatase inhibitors, firstly, we know that aromatase inhibitors are better than tamoxifen, but this study showed that there was maybe a signal that that difference in benefit was bigger in ILC as compared to IDC. So what these graphs are showing are IDC in the solid lines and ILC in the dotted lines. And then tamoxifen is in yellow and letrozole, one of the aromatase inhibitors, is in blue. So for IDC, the solid lines, there is a small difference between the two solid lines. We knew that aromatase inhibitors are superior to tamoxifen. But in ILC, the dotted lines, that difference in benefit may have been bigger. Subsequently, though, instead of just looking at one trial, this study now looked at 3 major clinical trials to see if that signal was still there. I know this is really hard to read. This is the best quality image I managed to get from their poster. But essentially, what this is showing is that once you pooled all 3 of the studies together, so not just looking at one clinical trial, but pooling 3 major clinical trials, that the difference between tamoxifen and aromatase inhibitor actually seemed pretty similar between ILC and IDC once there was a bigger population of patients included. So that signal that was seen in that one trial didn't really seem to pan out with a bigger population and more clinical trials. So I would say it's still not entirely clear that there's necessarily something different in ILC about tamoxifen really not working as well. And this is just something we should take into account on an individual case-by-case basis. So what about the duration of endocrine therapy? We know, this is shown on the left in the red and blue lines, that overall the long-term prognosis with ILC is slightly worse than with IDC. So does that change how long we should give their adjuvant endocrine therapy? And I'll back up by saying that that difference seems to start to increase at a later time point. So at this 5 to 10 years and then even beyond is where we're really seeing that difference in long-term prognosis between ILC and IDC, the recurrence rates. So the breast cancer index, also known as the BCI, is a tool that we can use to help us see if there is benefit to extending endocrine therapy beyond 5 years to the 10-year mark. And what the graphs on the right side are showing, this is specifically for ILC, is that the BCI is pretty prognostic. So in terms of looking at the rates of distant late recurrence, meaning a stage 4 recurrence at the later time point between years 5 and 10, that the BCI score does seem to stratify patients into those different categories of risk of that recurrence at a later time point, and that the BCI is predictive of whether or not we should give longer term endocrine therapy. So it does help in ILC specifically to have the BCI test, and it can help determine whether there is benefit to extending the endocrine therapy to the 10-year mark as opposed to 5 years. So this has been looked at in ILC specifically. I would say this is also a very personalized conversation because some patients have trouble tolerating their therapies due to side effects or due to, for example, bone mineral density worsening like osteopenia and osteoporosis as a result of long-term therapy. So at any time point, it's a matter of balancing the pros and cons, the potential benefit and how much benefit there is to extending treatment versus the cons of long-term exposure to these drugs that can cause worsening side effects. There are 2 drugs, 2 CDK4/6 inhibitors that can add additional benefit in reducing the risk of recurrence. These have not been looked at in ILC specifically, but were rather studied in high-risk, early-stage, hormone receptor positive, HER2 negative breast cancer, but I do think apply to our ILC patients. So the abemaciclib study is shown on the left, and the ribociclib study is shown on the right. And in short, what these are showing is that patients with high-risk disease, so big tumors, some axillary lymph node involvement, when they take a CDK4/6 inhibitor, either one, abemaciclib or ribociclib, in addition to their endocrine therapy, that there's further reduction in the recurrence risk. So for patients who qualify for these drugs, there's very specific qualifications for each drug that you don't need to know or memorize. But if patients qualify for these, they are adding significant benefit to patients' treatment regimens. Even though the adjuvant CDK4/6 inhibitors haven't been studied specifically for ILC, This was another analysis to look at which groups of patients do benefit from these CDK4/6 inhibitors. And one of the groups was the luminal A molecular subtype, which is a kind of hormone receptor positive HER2 negative breast cancer that tends to be slower growing, less responsive to chemotherapy, and more women with ILC, more tumors with ILC fall into this category of luminal A. And you can see what this is showing is that adding the CDK4/6 inhibitor abemaciclib to endocrine therapy, there was significant benefit in this particular subgroup, which is very applicable to ILC. This is another one of those analyses looking at oncotype scores. So in the red box that I've highlighted, patients who have low oncotype scores still derive pretty significant benefit from adding abemaciclib to their endocrine therapy. So even when the oncotype score is low and chemotherapy is not necessarily recommended, the CDK4/6 inhibitors can be beneficial in further lowering recurrence rates. A quick word on the LobSig gene signature. So this tool was developed based on almost 200 different genes that are turned on and turned off in ILC tumors, and used a composite of those genes to help determine a patient's prognosis. So this study team looked at these genes and looked at a group of patients and their tumor samples and categorized them into having LobSig high or low signatures. And it seemed that that was pretty prognostic of those patients' long-term outcome. These investigators have since refined their LobSig signature into looking at a smaller subset of genes and proteins that might be, again, turned on or turned off in ILCs, and found that their newer LobSig signature, LobSig4, was really able to divide patients into these groups prognosis-wise, particularly for ILC, and it didn't seem to divide those groups accurately in IDC or ductal. So we think that this is a very helpful tool for prognostication in terms of recurrence risk and long-term prognosis for patients with ILC. But this has been done on a relatively small set of patients and tumors and needs further validation in larger studies with larger numbers of patients and tumors to analyze. So in conclusion, for neoadjuvant therapy, HER2 positive or triple negative breast cancer, we follow the receptor subtype guidelines. So whether ILC or IDC, we typically treat based on tumor size, whether there are lymph nodes involved, and in making the decision of whether and how, which chemotherapies to give. For hormone receptor positive disease, there are low rates of pathologic complete response, and it's a complex multidisciplinary discussion about neoadjuvant therapy in general. For adjuvant post-surgical therapy for hormone receptor positive ILC, the oncotype score seems to be predictive of chemotherapy benefit, even in ILC specifically. So if the oncotype score is high, we are recommending chemotherapy. The tamoxifen data on whether there's a bigger difference between tamoxifen and aromatase inhibitors in ILC compared to IDC, those data have not really been definitive. So I would say it's not the case that we should say, oh, tamoxifen is just not effective in ILC, but rather it's an individual case-by-case basis, and it depends on how high that given patient's recurrence risk is, a bunch of factors, including their clinical factors as well as their tumor factors in making the decision of which endocrine therapy is right for that particular patient. The breast cancer index BCI does seem to predict whether there's benefit of extended endocrine therapy to the 10-year mark in ILC specifically, so that can be a very helpful tool. And CDK4/6 inhibitors like abemaciclib and ribociclib, also known as Verzenio and Kisqali, should be used in patients who are eligible because it is offering some additional benefit in reducing the recurrence risk. And lastly, LobSig is a highly prognostic tool that seems to be really unique to ILC, but it does require some more validation. So lastly, I just wanted to leave you with some resources on our MSK webpage. This is accessible to all patients anywhere. They can read about our lobular breast cancer program and read one of our articles about what is lobular carcinoma. So thank you very much for listening. I hope this recording wasn't too choppy. I got about halfway as a continuous recording and then it wouldn't let me advance the slides. So I ended up recording slide by slide. So thank you for bearing with me. Please don't hesitate to reach out if you have any questions, and I'm looking forward to the Q&A session that we'll record as well. Thank you.
Hello, everyone. My name is Julia Foldi, and I'm an assistant professor of medicine at the UPMC Hillman Cancer Center and a breast medical oncologist at the McGee Women's Hospital. I would like to give you an update on an interesting topic in lobular breast cancer, on unresolved questions in recurrence monitoring and treatment, as well as response monitoring in the metastatic setting. I will begin by describing a patient's case, someone that I follow in my practice, just to illustrate some of the challenges that patients with lobular breast cancer face. Then we'll talk about surveillance for breast cancer recurrence after completing initial therapy, the role for imaging, as well as liquid biopsy assays. And then finally, I'll talk about treatment and monitoring of treatment response in patients with metastatic lobular breast cancer. So I'd like to present this case of a 72-year-old woman who had a screening detected breast cancer. On a mammogram, she was found to have an approximately 3 centimeter mass in the left upper outer quadrant of her breast. However, her axillary lymph nodes under her arm appeared normal. She also underwent bilateral breast MRIs as part of her workup. This unfortunately estimated the size of the primary tumor to be larger at about 6 centimeters, but again had normal appearing lymph nodes. Then she underwent a core biopsy, which revealed lobular breast carcinoma with estrogen receptor being 90% positive, progesterone receptor 75% positive, and HER2 negative. She then underwent bilateral mastectomy and axillary surgery. And unfortunately, despite having normal appearing lymph nodes on imaging, she had 12 out of 15 removed lymph nodes that had lobular breast carcinoma found in them. And the total tumor in her breast measured 9.5 centimeters. Given that she had stage 3 breast cancer, she received adjuvant radiation as well as chemotherapy, and then started adjuvant endocrine therapy with an aromatase inhibitor. After a couple of months, abemaciclib, a CDK4/6 inhibitor, was added to her treatment to further reduce her risk of breast cancer recurrence. She's currently doing really well on her treatment, but often when she comes in for follow-up, she asks me these questions. How do I know if the cancer is coming back? And what are you going to do to monitor for it? These are perhaps the most commonly asked questions in the follow-up period by patients who are facing this diagnosis and just finished their initial treatment, whether that was surgery with radiation, with chemotherapy, and are now in this adjuvant follow-up phase. So what do our guidelines tell us? From our NCCN guidelines, what they suggest is that in the absence of clinical signs and symptoms suggestive of disease recurrence, there is no indication for laboratory or imaging studies for metastases screening. So why do they recommend this? These are based on 2 prior studies that were done back in the 90s. This is published in 1994, back-to-back articles in a journal called JAMA. Both studies looked at periodic imaging with CT scans and bone scan to allow for earlier detection of distant metastatic disease in patients with diagnosis of primary breast cancer. And these found that patients who had these periodic imaging done did not have improved outcomes compared to the patients who had no imaging done. And so as a result of this, our guidelines have ever since recommended against doing routine imaging as part of follow-up for patients with breast cancer. And this really gets to this idea of lead time bias, which I'd like to spend a minute explaining. So, um, as you can see on this graphic, there's two ways of monitoring for a recurrence. On the top would be a situation where somebody is getting routine scans. And on the bottom is the control group where patients are not getting routine scans, but they're being followed for any symptoms that could indicate a recurrence. You can see that at the point where these patients might have you got uh, a pointer. So at this time, when a patient would have a positive scan with the diagnosis confirmed, to the time that that patient dies is what we would count as overall survival or survival time. However, in the control group, they might have symptoms that developed later than in the screened group, and their diagnosis would be confirmed sometime after their symptoms appeared, and their survival time, therefore, appears to be shorter than for those patients who were screened. However, in reality, their survival time is exactly the same. What changes is the time that a diagnosis is confirmed. And so you can imagine that somebody on the top in the screen group would actually receive a lot more treatment that could potentially be toxic and create a lot of side effects while not making any difference in terms of overall survival. And so this is, again, one of the reasons that we think about surveillance the way we do today. So another specific issue in lobular breast cancer, as a lot of you might know, is that patients with lobular breast cancer tend to sometimes recur later, meaning that a metastatic recurrence could develop sometime even after the initial 5 years of follow-up, sometimes even after the initial 10 years. So how can we best define who's at risk? And can we use minimal residual disease monitoring by ctDNA, circulating tumor DNA, to monitor for recurrence? And I'll be discussing this over the next few minutes. Um, there are several questions that come up when we think about ctDNA monitoring. For example, how often will circulating MRD or minimal residual disease be associated with macroscopic disease, meaning disease that we can detect on scans? And what is the lead time, as I showed you on the previous slide? Can treatments alter the natural history of disease once somebody has detectable MRD? And if we can clear that MRD, meaning give a medication that can again make somebody ctDNA negative, can that be sustained? And if so, how long does the treatment need to last? And is that going to improve survival? And to get the answers to these questions, what is the best study design to understand, and especially in the setting of late recurrences? Um, so just to drive home this point about late recurrences, I wanted to show quickly the main results of a study that I have done together with some investigators from the University of Pittsburgh, as well as the NSABP, the National Surgical Adjuvant Breast and Bowel Project, which runs large phase 3 clinical trials. This was a study that we did based on 4 prior large randomized clinical trials that included over 12,000 patients overall, with about 15% of them having lobular breast cancer. And we looked at across these trials, how did patients do if they had lobular breast cancer versus what we call NST, carcinoma of no special type, which is also called ductal carcinoma. So as you can see, in terms of early in the follow-up in the first 5 years from diagnosis, the red curves representing patients with ILC are lower than these gray curves, meaning that patients with ILC have less early events and recurrences. However, when we look at events after 6 years of follow-up, We see that patients with ILC now tend to do worse with more late events and late recurrences than their counterparts who have ductal breast cancers. So we talked a little bit about ctDNA on the last slide, so I just want to define some things. So more and more we are using blood-based assays in oncology because these are minimally invasive, as one can see based on just a blood draw, to derive a lot of different information that can be helpful for diagnosis, um, for treatment selection and monitoring disease. So we know that tumors release both cells, intact cells, into the circulation. These are called circulating tumor cells or CTCs, as well as their DNA, called ctDNA. And this is often these short pieces of DNA that's derived from the cancer that is circulating in the blood. It's important to note that normal tissues, such as the liver and the lungs, also release DNA into the circulation. And so when we look at ctDNA, it's really important that we differentiate what DNA is coming from cancer versus normal tissues in the body. And then there's also other proteins and tumor-related materials that circulate in the blood, which there are novel technologies that are trying to assess how we could use these other types of materials for our advantage. Now, when we think about ctDNA and how we detect it, there are two main platforms or methods for doing this. One is called tumor-informed and the other is called tumor-agnostic. The tumor-informed platform requires tumor tissue, which is sequenced to make a custom panel of genes for that individual patient that is then tested from a blood sample. The primary use of this is to detect early stage cancers because this is a much more sensitive method, meaning that it can detect lower levels of circulating DNA. While the tumor agnostic platform does not require tumor tissue to be present, it is based on a technology called next generation sequencing, which uses any of the DNA that is found in the blood to detect specific mutations or alterations that we hope we can target. So this is generally used in the advanced or metastatic setting to identify targetable alterations such as mutations for which we have medications. And this is generally a less sensitive method, meaning that for someone who has very small amounts of circulating tumor DNA in their blood, this may not be able to detect that level. So how is ctDNA used currently in oncology? I'm showing here in black some established roles and in purple some emerging areas. So very often we are using ctDNA in the research setting to study tumor evolution and search for resistance mechanisms. In metastatic breast cancer, we search for targetable mutations and clinical trial matching. In terms of detection of germline mutations, these are the mutations that a person inherits from their parents. This can be done from circulating tumor DNA, although it requires confirmation. And then some emerging areas are tumor burden assessment and monitoring response to therapy in the metastatic setting, early prediction of response to therapy, such as prior to surgery, and then detection of minimal residual disease or recurrence risk estimation after completion of curative intent therapy or while on adjuvant therapy. I'll also briefly mention that these technologies are now being explored in early cancer detection in asymptomatic patients, but this is an area of research that's quite in its infancy still. So I think a lot of interest is in detection of minimal residual disease, and so we'll talk about this in the next few slides. So how do we currently estimate risk? Unfortunately, to circle back to that question that my patient asked is how do I know my cancer is coming back? we estimate this risk based on data from large populations. And unfortunately, this does not give personalized risk estimates. Even using personalized tests such as Oncotype DX or MammaPrint, which can give us an estimate of an individual's risk, these markers are also probabilistic. And so for any individual patient, we are not able to give a good estimate as to what that individual's risk is of cancer recurrence. Of course, this leads to uncertainty and anxiety for patients, leads to over or under treatment because physicians are uncertain of which direction to go in. So this is where we think that minimal residual disease monitoring can be helpful. So this graph shows the idea of how this technology can be used. So this curve represents a patient's path along their treatment from diagnosis to potentially a metastatic recurrence and progression. So on the left side, early on in the diagnosis, we think that circulating tumor DNA increases to a point where it can be detected. And this orange line here is the level of detection. Under that, currently, our assays are not very good at detecting DNA in the blood. So we can use these assays to detect cancer once it's at above this detection threshold. And we can monitor that while somebody is getting local therapy or, for example, neoadjuvant pre-surgical chemotherapy to see how they're responding to that. Then for a lot of patients, these ctDNA level will go to undetectable levels or even to zero. And of course, the majority of patients with breast cancer, early breast cancer, are cured just by these um, early therapies. But there will be some percentage of patients where the ctDNA starts rising again sometime during the follow-up period. And this is where we hope that we can design some interventions based on detection of this minimal residual disease that we can identify during follow-up. And the real hope is that we can design an intervention that can then kill those cancer cells that are sort of reawakening and put this patient back into a cure situation. Of course, there will be some people where this is not possible, and even though we can achieve a transient decrease in their levels, they will eventually rise and experience a clinical relapse, which would be something that's detectable by imaging, and then that cancer progresses through different treatment lines, as shown here. So again, this is the point where we really hope to intervene during follow-up in patients who are otherwise well and without evidence of cancer. Can we detect minimal residual disease and intervene? So this idea has been shown in previous studies to be very prognostic. So when we can detect minimal residual disease, that is ctDNA positivity in a patient, that means that that patient is most likely to have a poor outcome. And that is shown here in a large study in early stage breast cancer patients where a relatively large study. As you can see, these numbers are quite small, but this is one of the first studies that was able to show these differences that whether somebody is ctDNA positive at diagnosis, during follow-up, or whether patients have ER positive, triple negative, or HER2 positive breast cancer, those who are ctDNA positive, depicted in the orange curves, have much worse relapse-free survival than those patients who remain ctDNA negative in the black curves. And we have done a study specifically in lobular breast cancer in a collaboration with Natera, the makers of the Signatera MRD assay. We were able to show in a large cohort of over 20,000 patients with a subset of them having lobular breast cancer, that patients with lobular breast cancers appear to have more ctDNA positivity that's detected over the years from diagnosis than those patients who have ductal breast cancers. And this is true for all breast cancer subtypes as well as patients with ER positive, HER2 negative lobular breast cancers. And we think that ctDNA detection may be particularly important in lobular breast cancer because of this phenomenon, even though we don't fully understand the meaning of this just quite yet. We were also able to show in this same study that was presented at this summer's ASCO annual meeting that similarly to what we've seen on those curves from a couple slides ago, that both in the ductal population and in the patients with lobular breast cancers, whether somebody has a positive or negative ctDNA test at any point during their follow-up really affects their prognosis. With those patients who have detectable ctDNA and these bottom curves having much worse disease-free survival or distant relapse-free survival than those patients who have negative ctDNA. So regardless of histology, lobular versus ductal, having a negative ctDNA is good, and having a positive ctDNA test is bad in terms of prognosis. Now, there has been an idea that perhaps we can use CDK4/6 inhibitors, these new class of targeted medications, added to endocrine therapy for patients with early stage breast cancer who have ctDNA detected during their follow-up. These studies, of course, began prior to the approval of CDK4/6 inhibitors in the early stage setting. And so we have to still evaluate how relevant these studies remain today. But there are two ongoing studies, LEADER and DARE, which were screening patients with stage 2 and 3 ER positive, HER2 negative breast cancers who were on adjuvant endocrine therapy with the Signatera assays, and then randomizing patients who have a positive ctDNA to either continue the endocrine therapy they were already on or to add a CDK4/6 inhibitor, either ribociclib in LEADER or palbociclib in combination with fulvestrant for 2 years in DARE. So far, there are just some preliminary results of the DARE study, and we don't have any results of LEADER yet. So we've yet to see how this pans out. There's also an ongoing European study called TREAT ctDNA, which is evaluating the later time points. So again, this is very relevant to lobular because these are going to be patients who are 4.5 to 7 years on endocrine therapy, and they are planned to continue endocrine therapy. They are then screened again with ctDNA tests every 6 months, also using the Signatera test. And those patients who are Signatera positive then undergo imaging to assess for clinically apparent metastases. And those patients who do not have clinically apparent metastases, only ctDNA positivity, are then randomized to a novel oral selective estrogen receptor degrader called elacestrant versus continuing on their endocrine therapy for 2 years. And they're measuring distant metastasis-free survival in this study. Again, this is ongoing and we have no results yet. In the US, there is a similar study that's starting up led by my friend Maria Rosenblit from Yale University in patients who are at least 5 years from diagnosis, are no longer on their endocrine therapy, and they get ctDNA tests with a newer test called Personalis every 3 months for the first year and then every 6 months starting in the second year. Again, patients who have ctDNA positivity without any metastases detected on imaging will then receive elacestrant for 1 year. This is the same drug as in the European study. and they will continue ctDNA testing and staging scans every 3 months while on treatment, and then every 6 months during follow-up. This study is in the startup phases. We are going to open this at UPMC and other sites as well. So that concludes my portion talking about surveillance, and I'd like to move on to talking a bit about metastatic breast cancer treatment and monitoring for response. So this is a theoretical situation. I hope this does not happen to my patient, but this is something that we see quite often, that a patient would remain on their adjuvant therapy, continue on whether it's with a CDK4/6 inhibitor or endocrine therapy alone. Unfortunately, at some point, some patients will have a disease recurrence, just like in this case. Patient presents with progressively worsening hip and back pain, and imaging reveals widespread bone metastases. And the bone biopsy confirms diagnosis of recurrent breast cancer, ER positive, HER2 negative. She's otherwise healthy and is in good physical condition. So what is our current treatment strategy in this setting? Our first line treatments are very well established in this case. And as most lobular breast cancers fall into this category of ER positive, HER2 negative breast cancer, most of these patients would be treated with a CDK4/6 inhibitor plus endocrine therapy, either an AI or fulvestrant. So CDK4/6 inhibitors, they attack the cell cycle in cancer cells. They stop cell division, and this is how they slow cancer growth. I would just like to mention that over the last year or so, we've had a new approval for the first line setting for patients who have high risk and endocrine therapy resistant breast cancer and a PIK3CA mutation. So these are patients who would have a recurrence very early on while still on their endocrine therapy, and their cancer has a PIK3CA mutation. Then they're eligible for a triplet combination of a PI3 kinase inhibitor called inavolisib in combination with the CDK4/6 inhibitor palbociclib and fulvestrant. I would just like to mention that we do have an ongoing study at UPMC called LBC Monitor, where we're trying to evaluate whether ctDNA could replace imaging in monitoring for treatment response in these early treatments while patients are getting first-line endocrine therapy. So we're looking for about 20 patients with newly metastatic lobular breast cancer, either de novo metastatic or a recurrence. And we would be using the Signatera assay to monitor ctDNA every 4 weeks during the initial 12 weeks of endocrine therapy. And what we hope to do is define what happens to the ctDNA levels early on in treatment, and how we can use this to potentially define early response and tailor therapy better for these patients. What about beyond first line? So this is where things get really complicated. This is an area that's been very fast moving in breast cancer research. As you can see, the second and third line treatment of ER positive breast cancer is extremely complicated, and it depends on whether the cancer has developed or is carrying any mutations, such as a gene called PIK3CA, AKT1, PTEN, whether somebody has germline BRCA mutations, so these are inherited mutations, whether the cancer developed an ESR1 mutation, or whether the cancer has no mutations at all. These patients qualify for different types of treatment. What's really important is that ctDNA testing in the metastatic setting can identify the right patients for the right treatments. So we use, for example, Guardant or Foundation One, Caris. They all have liquid biopsy ctDNA assays which can identify these mutations. And what's really promising is, for example, in patients with PIK3CA mutations, which are very common in lobular breast cancer. As you can see, this is again from our study presented at ASCO that in lobular breast cancer, PIK3CA is the second most commonly mutated gene. So identifying patients for treatment with PI3 kinase inhibitors or PIK3CA inhibitors is extremely important. And now we have two different drugs, inhibitors of this molecule, alpelisib and inavolisib. Alpelisib is Piqray. Inavolisib, to be honest, I don't even know its brand name. It's a new drug. I've so far only have one patient who's qualified for inavolisib. Um, and I'm showing here the two large clinical trials that established their use. And then we also have another drug called capivasertib. That's an AKT inhibitor. These molecules are all connected within the same pathway and work to lead to cell proliferation and survival. So inhibiting these different molecules can lead to arrest of the cancer growth. And again, very important to identify the right patients for these right treatments because, for example, on the Inavo 120 trial, we saw that in these very high-risk patients, the patients who received the control treatment on average lived 7.3 months without progression, so progression-free survival. And this nearly doubled in those patients who received a new drug, inavolisib. So very important to identify these patients for these targeted therapies, which can be done using ctDNA. What about chemotherapy and other kinds of treatments? So we know that when these ER positive cancers are treated with endocrine-based strategies, eventually almost all cancers develop resistance to endocrine therapy. And at that point, we usually move to other types of treatments like chemotherapy, like antibody drug conjugates, as shown here. And nowadays, our treatment algorithm gets quite complicated depending on whether somebody's cancer has a HER2 low status or nowadays even a HER2 ultra low status. In those cases, patients can receive a drug called trastuzumab deruxtecan or Enhertu. And then we have novel antibody drug conjugates, Trodelvy or sacituzumab govitecan and datopotamab deruxtecan that are now also newly approved in this setting. So just a word about what it means to be HER2 low. So HER2 is another marker that we use in breast cancer very frequently and is measured using a test called immunohistochemistry. And these are the four different results of an immunohistochemistry assay. Either somebody is completely negative or zero. They can have HER2 low disease, or they can have clearly HER2 positive, strongly positive 3+ disease. So it's this middle category is what we consider HER2 low. And there has been a lot of development over the last few years, developing more and more effective drugs in this setting. And trastuzumab deruxtecan is the first approved drug which works not only in HER2 positive but HER2 low breast cancer. This is Enhertu, and this graphic is just showing how these drugs attach to the protein HER2 on the cell surface. The chemotherapy is then internalized into the cell. The cell undergoes cell death. And what's important also is that the drug then exits the dying cells and can work in the tumor microenvironment, killing other cells, is what we call bystander effect. So moving on to a slightly different topic, I want to spend just a couple of minutes on talking about ILC specific treatments. So as you might know, we currently treat lobular breast cancer similarly to ductal breast cancers, despite the biological differences. But there are some ideas for how we could design novel strategies that are specific to lobular patients. And this is one example. the Gelato trial, which was conducted in the Netherlands, which explored immunotherapy for patients with ILC, combination of a chemotherapy drug called carboplatin and the immune checkpoint inhibitor atezolizumab. So most of the patients on the trial were actually had ER positive, HER2 negative breast cancer, with some having triple negative ILC, some patients with pleomorphic lobular breast cancer. And this is what's called a waterfall plot where you can see how patients responded to the treatment. The lower these lines go, the more the cancer shrunk on the treatment. So it's these red bars, which are representing the patients who had a partial response to therapy. And as you can see, 2 out of the 4 of them had triple negative ILC. But overall, as you can see, about half of the patients had progression of disease, and only about a little less than half of the patients had any kind of response to this treatment. So it's unclear why some of these patients respond better than others, but this is not a slam dunk for lobular breast cancer. Another trial called the Rollo trial was conducted in the UK, targeting a pathway called ROS with a drug called crizotinib. Unfortunately, these results were presented recently. There was not an impressive progression-free or overall survival in this small study, and so it's a little bit hard to say where this is going to go, but there are a couple of other trials with similar ROS pathway inhibitors. One is currently ongoing at MD Anderson with reprotectinib, and another one that was planned to be at the Cleveland Clinic with taletrectinib. This was suspended because of changes in the pharmaceutical leadership, and they decided not to move forward with the study, unfortunately. So, in conclusion, ctDNA is a powerful tool for research, for identification of targetable mutations that allow new treatments that otherwise wouldn't be available, and possibly for minimal residual disease monitoring. In early breast cancer, multiple studies show strong association between ctDNA presence and distant recurrence, but so far no study has shown that intervening on a positive test improves outcomes or that de-escalating therapy based on a negative test is safe. So given this lack of evidence that ctDNA-guided therapy in early breast cancer improves outcomes, using ctDNA results to guide therapy should only be done as part of a clinical trial at this time. There are lots of studies ongoing and the technology continues to improve. So I do believe that in the next 5 to 10 years, this is going to change. In metastatic ER-positive breast cancer, the treatment is extremely complicated. Patients with ER-positive lobular breast cancer right now are treated the same as anyone else with an ER-positive breast cancer, and we need more data and trials to evaluate ILC-specific treatments. And with that, I would like to thank for all of your attention, and I will be happy to take any questions in the Q&A session. Thank you. Bye.